Good morning, everyone, and welcome to our May webinar with the Michigan Vaccine Project. We are going to be speaking to immunizations for women in celebration of May Women's Health Month, but we'll also ask and answer some general women's health questions. So good morning and welcome, everyone, and welcome Dr. Gendernalik. And I will turn it over to you for a brief introduction before we start on our questions.
Good morning, everyone. I'm Dr. Bernadette Gendernalik. I'm from the Department of Family Medicine. I'm an assistant professor at Michigan State University College of Osteopathic Medicine. I've been in family medicine for over 36 years in the Macomb County region here in Michigan all my life. And I did 20 years of obstetrics in family medicine as well as general family medicine, and then the last 16 years in office space. In family medicine, we're cradle to grave, if you will. And so therefore we do run the whole spectrum of care. So I'm very happy to have been asked to help with Women's Health Month, and here we go.
We certainly appreciate your wealth of expertise and thank you so much. So just as a side note, we will be adding the survey, the Qualtrics webinar evaluation survey in the chat. And for those who will be watching it later, it will be associated with the post on our MVP website. So to get us started off, just a couple of general questions about women's health that'll be leading into some vaccine and immunization specific questions. But Dr. Gendernalik, why do you believe that women's health is important?
Gosh, because we women are important. And I think that's like the number one thing. I'm a mom, a wife, a doctor. Which hat am I wearing, right? The grass cutter to the bathroom cleaner. And for women, unfortunately, we sometimes do many things, but forget about our own health. And unfortunately, if we are not well, physically, spiritually, mentally, the whole situation can fall apart. And so the idea here is to try to do our best to help with prevention, help with early detection for heart disease and cancers, things of that nature. And so I think it's really important to kind of review and go, I'm no less important than anyone else in my family or community. And again, without us, they would be sad. Definitely want to let women know we have to be at the forefront for our care and partner with whoever your healthcare provider is. And it is a partnership.
Exactly. What a great introduction to our day for you to bring that perspective about women's health. So another kind of general question is, what can women do to stay healthy as they age in general terms?
So certainly our nutrition, our physical activity, but also having those visits with our healthcare provider, typically on an annual basis. There's many different tests and exams that need to be done at certain times of our life. And having that partnership on an annual basis to say, okay, I'm at this age, what do I need to do? Or I'm getting ready to have a baby, what should I do before I ever get pregnant? Or I'm over 50, and what does that mean for my health? With healthcare so rapidly changing and new information all of the time, I think it is important that you have that annual exam, and we can touch a little bit about what that might mean depending on the age as we go along.
Okay, thank you. And you mentioned pregnancy, and as we move into some of the more vaccine-specific questions, one of the questions is, what vaccines do I need to think about before I get pregnant?
This is a very good question, and really that pre-pregnancy consultation can be with your obstetrician gynecologist, can be with your family medicine or internal medicine specialist, any one of them. Basically looking at after age 19 and looking at vaccines that need to be boosted or updated. So the first thing regarding viruses would be our annual flu vaccine and our annual COVID vaccine. These vaccines would typically be done in advance of the pregnancy, but unfortunately, sometimes we get pregnant and didn't plan on it. Those vaccines can be given also during pregnancy. The tetanus whooping cough vaccine, with women who are actually pregnant, it should be given with every pregnancy about 8 weeks before delivery. However, in the general population, we should be boosted every 10 years for that tetanus whooping cough, and between the 5th and 10th year if we have a dirty wound. Typically, the children will be boosted at 12, somewhere between 10 and 12 years of age, and then all of a sudden we forget about it. And so this is where taking a look, when was your last one? Let's get you updated, I think are really critical to try to help. The other would be if an individual did not have a hepatitis B vaccine, the CDC, the Center of Disease Control, is recommending that the age group between 19 and 60 be caught up on their vaccine. Many people, of course, get it in infancy and have for the last 20 plus years, but some people might not have gotten it. So ideally, we'd like to have had that done. The measles, mumps, rubella vaccine typically is at 12 months of age and again at 5 years. So the majority of women in 2024 who are contemplating pregnancy should have already had it. But however, if they have not, then we certainly would want them vaccinated in advance of that pregnancy.
Okay, so you did mention a couple of those that were during pregnancy, and there was a specific question. I don't know if you wanted to add any about what vaccines are recommended during pregnancy, and address, because there is some hesitancy, unfortunately now, if they are safe, if it's safe to get vaccinated during pregnancy.
Yes, it is safe. There are certain vaccines that we don't typically give during pregnancy, and those are the live attenuated vaccines. And however, the vaccines that we focus on during pregnancy, which would be the tetanus whooping cough vaccine, your flu vaccine injection, not intranasal, because that is a live vaccine, the COVID vaccine, and now, as of 2023, the RSV, or respiratory syncytial virus vaccine, which is also given. The RSV and the tetanus whooping cough, the goal is to give those about 6 to 8 weeks before delivery so that the mother can transfer antibodies to the baby to help that baby once the baby's here. And again, that prevention to encircle that baby.
So important, so important. And I believe you had an experience with a relative that you were willing to share about RSV.
Yes, so in the many years that I've been in practice, a frustration, I think, for all of us who care for babies is the respiratory infection of RSV. And because until last year, we did not have a vaccine to help prevent, nor do we have any medication specific for that virus. And even up to last year, the babies who are under 12 weeks of age, certainly who get infected with RSV, have a much higher chance of actually severe respiratory issues where they need to be hospitalized and their oxygen monitored. And the other part, once they get past their acute infection, is chronic inflammation that happens in the airways many times for at least the first 2 years of life after being infected. So in July last year, I have a niece who there was an outbreak of RSV in Georgia, and her little one was 5 weeks old and was infected and was in the intensive care unit, had to have feeding tubes, had to have high oxygen, and was in the hospital for about a 2-week period of time. Since that time, and again, that was July, and then the vaccines were approved in August last year for not only the pregnant woman to transfer antibodies, but also for adults who are over the age of 60, and because of problems that can happen the older we get if we get RSV. But the other part of that is that the older adult, the grandparent perhaps, could get RSV and give it to a baby. So there's two protections for that 60 and above, both for chronic illness of that individual, but also to help protect a newborn that may be in the home or someone that you're caring for. So that vaccine, and then also the tetanus whooping cough, Tdap, pertussis, or whooping cough. And although that is a bacterial infection, the toxin from it is what severely inflames babies' airways. And so the vaccine is given to mom about 6 to 8 weeks before delivery to transfer antibodies to reduce the risk of that baby getting it. But we also encourage those individuals who haven't had a booster, who are going to be around that baby, to be boosted as well in advance of the baby being born. The tetanus whooping cough for the baby, those vaccines don't start until the baby is 2 months of age, and they need their first 3 to be protective. So getting that pregnant woman in the best shape, being vaccinated for things that can not only hurt her, can hurt the baby as well. We also have to remember during pregnancy, mom is giving the oxygen to the baby. So if mom gets influenza, if mom gets COVID, oxygen reduction does not help mom and absolutely doesn't help baby. So again, trying to do our best at some prevention to reduce the risk of mom having issues and baby having issues. So
we certainly appreciate you sharing that personal story. Those stories are what make it real for our listeners and for staff too. So we appreciate you sharing that. And you really have tapped into a couple of follow-up questions. One of them is, should anyone around me get vaccinated? And that, I think that you addressed that. I don't know if you want to say any more about that, but the importance of knowing that these little ones who aren't vaccinated, it's very important that those adults around them get vaccinated too,
yes.
so that it's not spread to them.
And again, another story regarding whooping cough and pertussis, where a grandparent was not vaccinated in advance and had pertussis. And unfortunately, initially pertussis, you have a mild cough, and then by about day 7, your cough is much worse. The problem is that she didn't know. She had a mild cough to begin with, and the infant was actually 2 weeks old, and also then had pertussis. So the idea is to vaccinate around an infant who can't be vaccinated, so that influenza, the COVID, influenza and COVID for babies isn't until 6 months of age. So again, even if you're hesitant about vaccine for yourself, think about the small child that might be around that's too young to be vaccinated yet.
Yes, and if you haven't heard a small infant who has pertussis or whooping cough, Google it, because it is a heart-wrenching sound. There's a very unique sound to that is heart-wrenching.
Very scary. That inflammation of the airway, very scary.
Yes, yes. So one more follow-up to that, which you touched on a little bit, and that is, I have heard about passive immunity being on the immunization schedule. What does that mean?
I think from the idea here is, in a pregnant woman, it's going to give immunity passively to the baby and having those vaccines done in advance of delivery, and ideally at least 6 weeks before. So those are really the primary. The flu, the COVID, the pertussis, and RSV now should be all done to try to improve immunity for the baby during the time frame of them not being able to be vaccinated.
Okay. All right, thank you we're going to ask a few questions that have some definitions or clarification, because it can be confusing to know the difference between some of these words. And that goes right into my next question that you mentioned briefly about live vaccines. So what is the difference between live and inactivated or other kind of vaccines that you want to share?
Great. So when we look at vaccines, We have live, which are a weakened form of the virus that is a vaccine. The 4 that are here in the United States that we still use are the MMR, the rotavirus, the chickenpox vaccine, and the intranasal flu vaccine. Now, these vaccines typically are not given during pregnancy because they are live vaccines. And the MMR is at 12 months, and again, typically at kindergarten. The rotavirus is for an intestinal virus that affects babies, and that's given in the first 12 weeks. It should be completed during that 3-month period. The chickenpox vaccine, which is given at 12 to 15 months and then at kindergarten. And then the intranasal flu vaccine, typically in the younger population through age 45, as long as they don't have any chronic respiratory problems like asthma. So those vaccines are live, but they are from a weakened type of virus. So typically you would not get the infection even from this vaccine. All the other vaccines that we use are typically a portion of the virus. So it's a protein or a piece of the virus that is utilized to make that vaccine. So those are like the 2 different. The newer ones, like with COVID vaccine, mRNA vaccines, and so on as well. These are not live vaccines. The vaccines like the oral polio, which we do not use any longer, the oral polio here in the United States, at least, the oral polio was a live vaccine. But because we've pretty much eradicated the polio virus, now it's injectable as opposed to the oral. And the oral you could actually give to one person, and because it went through their intestines, they could potentially help another person in the family. But we don't use that vaccine any longer.
Well, and you
Smallpox
mentioned
was another one that many of us used to have our scar from our smallpox, but smallpox was eradicated and we no longer use that vaccine except in specific circumstances. There are some vaccines that are used in the military, but those are very specific.
And you mentioned the eradication of some of those, and sometimes since we don't remember those, it's easy to think that the vaccines aren't as important, when in fact, the reason we have eradicated them is because of the vaccinations we've gotten over the decades prior to now. So you had even mentioned that some physicians haven't seen some of these and so have to rely on, unfortunately, learning the
Books
information.
again.
Yeah, right.
Yeah, the MMR, the measles, mumps, rubella is an excellent example currently right now happening here in the US. Unfortunately, during COVID early on, and even now, they were still running that race of getting our numbers back up on vaccine. And with the reduction of numbers of being vaccinated, we have seen outbreaks of measles again, which we hadn't seen. And so just over the last 3 months since the beginning of the year, 4 months, we've had spattering of outbreaks through the US, mostly by virtue of individuals traveling to areas where measles is still happening at higher amounts and the individual not being vaccinated. So again, the vaccine time is 12 months. However, infants who are going to be traveling can be vaccinated earlier. It doesn't count as their number 1 and number 2, but it does help in preventing illness. And again, especially the MMR, where we hadn't seen it and now are, and definitely from a physician end, having to reopen the books and look at the signs and symptoms and so on of it. One thing to mention regarding why I spoke briefly about the chickenpox vaccine being a live vaccine, which it is, but when we're older and we get the shingles vaccine or Shingrix vaccine, that is not a live vaccine. And so I know some people have questions about that and getting it, which is to be given at 50 years of age and above. That is not a live vaccine, and it helps our immune system keep that virus in check.
Yeah, thank you for clarifying that. We're going to shift just a bit to another question about breast cancer. And the person said, breast cancer runs in my family. What can I do to monitor my risks, or when should I seek medical attention? And then what vaccines are available to help reduce my risk of cancer?
Sure. The idea about preventing, I think maybe I'll take the vaccine first and then breast cancer and the colon and lung cancers.
Okay.
Currently, we have 2 vaccines, the hepatitis B and the HPV vaccines. These 2 specifically to reduce the risk of cancers. The hepatitis B in relation to liver cancer, and the HPV, or human papillomavirus vaccine, for primarily cervical, genital, anal, and oral cancers. So that's a lot of cancer groups that this virus vaccine markedly reduces the occurrence of. The HPV vaccine has actually been available since 2006. It was adjusted to have a wider number of virus types in it after that in 2014. And we now can give it from age 10 all the way to age 45. So this is really critical, because when we look at cervical cancer and pre-cancer changes, and the numbers have markedly reduced, both the pre-cancer changes as well as cancer, by virtue of the vaccine. And initially, the focus was on women and being vaccinated. Our focus today is for men and women to be vaccinated. Unfortunately, oral cancers from this virus are higher in number than the cervical cancer currently. So this really is both male and female. It's just, if you're human, you should be vaccinated, period. And we don't have to think of sex or gender, but if you're above the age of 10, if you're all the way to 45, you can be vaccinated. I think the important part there, it was only till 26 and then it was changed, is that our life changes sometimes. Whether we plan it or we don't plan it, things do change. Be a death of a partner, a divorce of a partner, you may have only been sexually active with one person and now there's potentially a new partner. And HPV is sneaky and you may not know you have it. And so being able to have this vaccine to markedly reduce these cancers, and very good numbers now because of the number of years we've had the vaccine, that we can see the reduction of these cancers. So reviewing with your healthcare provider, again, I don't think I got it when I was 15. And I'm 25 now, or I'm 30 now, or I'm 35 now. And those discussions, I think, are very helpful just for what's new and what should be addressed at any of those ages. So those are the 2 vaccines. And again,
really,
I had noted previously regarding the hepatitis B that it is recommended that catch-up be done for individuals who are between 19 and 60. For that vaccine as well.
And really, what an amazing success story for both of those. I don't know if the public knows so much that we have vaccines that prevent cancer, and what a success story that is. I think it's getting out there more about HPV and preventing cervical cancer, but I think we can do a better job about making people aware that's also all of the cancers that you said that were associated with the HPV vaccine, and that it isn't just women, although women are, I like your statement about humans.
And I think, even with children coming to the doctors, the majority of times it's their moms that come. And again, to be educated and advocated, and when dad comes, absolutely too, because these are human vaccines, not gender specific. And I think that's really important.
And what a great way to say that. Okay, so You have addressed this a little bit here and there, but what are some annual or regular tests, vaccines, or checkups women should be thinking about and scheduling? And we have a couple of breakdowns of whether you're under 50 or you're over 50.
Okay. So I'll try to stay on task we'll do the younger folks first. So there are some changes regarding guidelines for cervical cancer screening. And so when a woman goes to the doctor for an annual exam, so you may see at 21 doing cervical cancer screening, either by pap test, looking at abnormal cells, or the HPV virus testing. Some guidelines have changed that to age 25 in using the virus testing, the HPV testing, that looks at the cancer, the types of HPV virus that cause cancer. And so this screen is still done using a cervical swab. When they're both done together, some of the guidelines say then every 5 years, the testing should be done. Others are now just HPV testing alone and on a 5-year interval. This would be done all the way through age 65, and that would be adjusted if a woman, in fact, does have a precancer change or a cancer change and the follow-up there. But in the general population, the HPV and PAP at 5-year intervals, now specific to that's the testing, right? But it doesn't mean you don't get a physical exam. And I think that's really imperative that our number one cancer is skin cancer, right? Above everything. So having your physician, your healthcare provider doing an annual exam to check for skin changes, if nothing else. Certainly helping to teach on breast exams and so on, making sure that pelvic wise, everything appears normal, size of uterus, ovaries, the integrity of the pelvis. So there's a lot more to check than just checking for that cervical cancer or precancer changes. So still having that annual exam to have a good head to toe evaluation, I think is really very important. The breast and breast cancer screening typically is at age 40 for your initial mammography. We encourage that it be 3D mammography. And again, that does not include women who have had first degree family members with early breast cancers, or if they know they carry a genetic marker. That's different, and that's on a case by case scenario. But when we look at most common cancers, so skin cancer is number one, but number two for women is breast cancer. And when we look at the general population, 1 out of 8 women will be diagnosed with it. And so these guidelines, the American Cancer Society, they have had 40 consistently for quite a number of years. The U.S. Preventive Task Force just changed theirs to 40, actually like a week ago or 2 weeks ago. So every year to every other year is really the standard. Through at least age 75, and again, between 75 and 80, it's based on the individual and their general health. And so again, a discussion with your healthcare provider as you age. The colon exam to be done as a screening starting at age 45. It used to be 50, it is now 45. That's the general population, men and women. And again, if there's a family history of colon cancer, or the individual has like Crohn's disease or ulcerative colitis, those screenings are going to be adjusted younger. But for the general population, that colon exam should be done as a baseline at age 45. And then how often it is dependent on what's found initially. The other, in regards to women, since this is focused on women, but both women and men, and this is really important, which is our lung cancer screening program. I think sometimes this is forgotten, but we've been doing it for well over 15 years. The guidelines have changed a little bit regarding how early and the number of packs of cigarettes a day, but 1 pack a day for 20 years. And if the individual is at 50, they should be getting screened. What is important and what has changed since a year ago this time was that they dropped how many years you haven't smoked. So one of the criteria used to be if you stopped smoking more than 15 years ago, then you weren't part of that program for screening. That is no longer part of it. It's only the number of pack years and your age. So that again is another reminder to speak with your healthcare provider about, am I due? Is it time for that screening? So your general skin exam, your mammogram, starting at 40, the colon cancer screening at age 45. Unfortunately, our number one cancer that women die from is lung cancer. And number 2 is breast, although breast cancer is more common. So, and I think to come back in general for women's health, the number one cause of death is coronary artery disease or heart disease, and tobacco products and so on to be aware of and where we sit with that, as well as general health, high blood pressure and diabetes screening, cholesterol screening. So depending on the family history and then the individual's history.
And you had mentioned while we briefly spoke before the webinar started about a press release on May 3rd from MDHHS, from Michigan Department of Health and Human Services. I don't know if you wanted to touch on that, and I can put the information in the chat as you speak about that.
Yeah, that would be great if we put that in the chat. So some women will go, look, I can't afford it. I have a high deductible or a copay. But on Friday last week, the Michigan Department of Health and Human Services did put out a press release bulletin regarding a program for regular breast and cervical cancer screening and for low-income individuals. And we will have on the chat both the email that you can, or the website you can go to, and the phone number, and locations where we're able to provide these services. So I think that is incredibly important because, again, cost affects how we care for ourselves. And this is a new program and hot off the press. We'll have that information for everyone.
I have put it in the chat, and thank you for that information. Very current and timely. So the next question, which you touched a tiny bit on here when you were speaking in the last question, but what is the difference between a pelvic exam and a pap smear or HPV test, and when do I need to get them? And for instance, as you were speaking on the last question, I thought, why did the recommendation change? For instance, as I was growing up, we were to get them once a year, and now it's 5 years. So maybe you can, if you can address all of the difference, and then when we should get them and why that changed.
Yes. So originally, there was just cervical cancer screening with Pap tests. Pap tests looked at cells from the cervix and whether they were normal or abnormal and how abnormal they were. As time went on, we found that it was a virus that caused it, the cancer and the precancer changes, human papillomavirus or HPV. The strength of knowing whether the virus is active really is what drives knowing if you're at higher risk for a precancer change. And so over time, we have found that if that virus is active, you need to be monitored more closely. We also know that if you get infected with the virus, about 80% of the time, your own immune system can fight it. But unfortunately, there's a 20% that may go on to a precancer change or invasive cancer. So the weight of knowing if the virus is active and shedding in a high amount is incredibly important. And what was found is that in an individual who has a normal immune system, then typically the majority who are infected, which are a younger population, between 15 and 25, are either now vaccinated or will resolve their infection. to go from being infected with virus to actual invasive cancer takes a number of years, unless an individual has some immune compromised problem going on. So what was found is that monitoring at 5-year intervals was even more effective because it reduced the risk of having to do too much, actually, and doing biopsies that may not be needed and so on. So the weight of checking for the virus is what's really important now, and then utilizing them at these intervals because of the number of individuals who can fight the infection or having had the vaccine. So those are the reasons for the screening intervals to be 5 years. That doesn't necessarily mean you don't see your doctor but every 5 years, or you don't have a pelvic exam, because again, there's other things to look at. The skin in the genital region can have precancer changes or cancer changes. You can have melanoma, which is a skin cancer, but you don't see it and your doctor needs to evaluate it or see it. Again, precancer perianal region issues, genital warts. For women who have had babies, to evaluate the integrity of the bladder and everything being held up or not. And so still having that general exam, I think, is very important, again, for other reasons. You can have fibroids, which are benign growths on the uterus, but they can get very large and cause pelvic pressure and so on. So that, again, the physical exam versus what's screening and trying to piece through those.
Thank you, and for that explanation, and again highlights the importance of getting vaccinated, and not just for cervical cancer. And the HPV vaccine, as you've mentioned throughout this, is also for other preventive to prevent other forms of cancer too. Yeah, thank you.
And I think, just to reiterate, because I hear this as for their exam, my doctor told me I didn't have to have this, but every 5 years. Again, the screening, that's true, but it's not the physical every 5 years. And that's a separate scenario.
And also during your annual physical, your healthcare provider will likely speak to you about vaccines, and you can ask them at that time if you're up to date or if there are any new boosters out or all of that. So very important to see your healthcare provider for that annual physical. So,
yeah. So one thing that I did in
Mm-hmm.
regards to the above the age of 50 and cervical, well, we'll do cervical cancer screening first. So if you've been followed consistently for a 20-year period, and now you are 65, and you've never had an abnormal PAP or you've never had positive HPV testing, and it's been consistent, then it's true, the screening at age 65 is complete.
Okay.
But that doesn't mean you don't have a physical, right? It just means that you are at such low risk because you've been followed well that you may no longer need the sampling done. Now, certainly if at any time there is postmenopausal bleeding or a discharge or so on, again, that always has to be evaluated or investigated. From the vaccine end above the age of 50, I touched base a little bit regarding the shingles vaccine, which is to help reduce your reactivation of the virus that you unfortunately acquired as a little one. If an individual is above the age of 40, and even probably 30 and above, if they've had chickenpox, they have the virus. And the idea is, as we age, our immune system has a hard time keeping it in check, and it can reactivate along a nerve, causing severe pain. It can be the chest wall, can be the face. And so having this vaccine, the shingles or Shingrix, at 50 reduces that risk of reactivation. So that's really important. The RSV vaccine, I already went over. Again, that's at 60 and above, and that's probably our newest vaccine because that was released last year. The pneumonia vaccine, which primarily Prevnar 20 now, is 65. Now, there's still the annual flu. There's the annual COVID as well. Those are vaccines for the 65 and above.
Thank you for including those as well. Yeah, I don't think we had talked about pneumonia specifically. It's a good one to mention. So I think that you already answered the questions about screens like colon cancer and lung cancer. So the next question is a deviation a bit from the vaccines, but is it important to let my healthcare provider know about my use of substances? So alcohol, nicotine, marijuana, or THC products?
So I think that's very important that we have that open door policy between the healthcare provider and the patient to really understand and know what an individual is taking. Not only what are they ingesting or inhaling, but how much. So one of the areas that I encourage our medical students, and I teach first and second year medical school, is if you ask the question, do you smoke? And the person may say, no, I don't. Then did you ever? And do you use any other nicotine products? Because vaping is absolutely our number one use in teenagers now. And we don't have enough data. We'll know over the next 20 years. The downside, not only we know it for nicotine, but the inhalant and the cartridges and so on, what negative effect. We do see that if people use vaping, both nicotine and marijuana products, that the inflammatory reaction in the lungs is higher. And if you end up getting, say, influenza or COVID or RSV, and you vape, your risk of complications is also higher. The other part is people don't think that the nicotine inhalant has an effect. It does. It's a constrictor, and it's associated with coronary artery disease. And so some of these cartridges, one cartridge is nicotine equivalent to one pack of cigarettes, but there are some cartridges that can be equivalent up to 3 packs of nicotine. So these are all new questions that we have to train ourselves and our physicians coming through. The marijuana and THC. THC can be inhaled, it can be topical, it can be edible. And how much and what effect? The combination of that and alcohol. Alcohol use, somebody may say, I have 2 drinks at night when I get home. That's 14 a week. I mean, you don't think about that. And what effect for women, we have a more difficult time processing alcohol than men. So it's less amount with an equivalent effect. And so being mindful of those things, and again, for general health, for your lungs, for your liver, for your stomach, both tobacco and alcohol effect on the esophagus and on the stomach and on cancers associated with those. So whatever the product might be and whatever delivery system, important to know. In some of we're in an area in Macomb County, we have the Air Force base here. And one thing, when marijuana was legalized in our state, even though federally it's not, we all received notification that we need to be educating any of our active duty military, because if they test positive, even from a lotion or a cream or a gummy that they didn't think, there's consequences. So just being aware that cream that has THC in it gets absorbed and may have an effect. Important to let your healthcare provider know that.
And that information, it was great to know, and I think really came to the forefront during the pandemic, when if you were immunocompromised or you were at risk or high risk because of a respiratory issue, and the importance of getting vaccinated specifically for those people, because they were more at risk of having a respiratory problem if they had asthma or if they had some other respiratory issue that might be associated with the use of some of these substances. Yeah, very good information, and tying that back into women's health as well. So we have a couple of more questions. I'm going to go ahead and put the evaluation link in the chat right now so that people have a bit of time to fill that out if they want. And everybody that watches this should complete that survey. But so the next question: with so many years of experience as practicing healthcare provider, from your perspective, how has the state of contagious or infectious diseases in vaccine utilization changed? And specifically for women, since it's women's health.
So I think one unfortunate thing is the reduction of vaccines that has happened, certainly in 2020, 2021, and 2022. Last year, things were going up a little bit, so that's a good thing. I think being able to have some sort of dialogue with your healthcare provider about these vaccines, about understanding the health risks versus benefits, that the benefits far and away, 1 million people over that have died of COVID. And the effects, had we not had that vaccine.
In this country, 1 million in this.
Exactly. Yeah, that's not the world, that's the United States.
Mhm.
And to note that there have been viruses, the measles, that were nearly eradicated, and now we're seeing again. And people haven't seen chickenpox encephalitis. I have. Pregnant women who get measles and the babies have both hearing and heart effects from it. These are critical things that we move far and away from and now are back again. And again, having that discussion, yes, it means it takes a couple minutes. And from a healthcare end, we have to be able to help work through these things with our male and female population. And again, women see physicians more than men, unfortunately. And they are the spokesperson, I think, and the advocate for improved healthcare. And again, my focus would be, I would like to prevent than have to chase something, whether it's a viral infection, a cancer. If there's either prevention or early detection, I want a polyp in the colon. I don't want cancer. I want very early cancer of the breast, not invasive. So we're still going to see these cancers. We can't not. But I think when we look at, I think some of the information I was reading, only 7 out of 10 individuals who should have had colonoscopies have done it. And this is all just United States data, that we want to work to prevent or detect early. And that really is, those are my 2 goals.
Very commendable goals. I agree with them. So to wrap up, just what some general health advice do you want to give specifically to women that you may have not have covered already?
I think just again, reminding everyone, do your annual exam, find out what you need based on your age and your risk. Family risk changes all the time. And it may mean even, hey, I had a normal mammogram 6 months ago, but I feel a lump right now.
Mhm.
What should I do? You should go to your doctor, okay? Because it can still be there. And again, if family history changes, make an appointment with your doctor to sit down and talk about it. Don't wait till your annual physical 6 months from now to go, here's my list. Come in sooner so that we can sit down and go over those risk assessments and find the best care for you.
Thank you so much. I think that is all of the questions that we have. I don't know if you had any final words other than what you've already shared, but we certainly appreciate your involvement in the Michigan Vaccine Project webinar series. And any final words before we end?
No, just get out there and vaccinate and get your annual exams and chat with your doctor about the changes that might be happening in family and yourself. Don't wait.
Great. Thank you so much, Dr. Gendernalik,
Thank you
for your participation. Thank you again.
Take care.